Okay, so today we're going to chat a little bit more about coronary heart disease, an introduction to atherosclerosis. So last week it was just a kind of overview of what cardiovascular disease is. So cardiovascular disease is essentially the buildup of fatty plaques that affect your arteries, which can affect your heart, your head, or the arteries pretty much anywhere in your body, in particular your legs with peripheral vascular disease. But today we're going to hone in a little bit more on coronary heart disease. So we're going to chat a little bit more about the heart. So essentially the heart is, it's a muscle, and it's about the size of your fist. And I often chat to patients about this. Okay, your heart's about the size of the fist, and its main job obviously is to pump blood around your body. Okay, and your average beats per minute usually lies between 60 and 100 beats per minute. If it's less than 60, it may be perceived as being bradycardic, a little bit slower, or if it's more than 100, you would be tachycardic. Okay, so instances where it would be more than 100 is if you're exercising, or indeed if you were unwell, if you had sepsis. Lower beats per minute can happen if you're fitter. So basically, my resting heart rate now would be less than 60, and I don't think it was before I started TSD. So essentially, I'm going to show a picture here actually of the heart, so we can have a look at the coronary arteries. Little cartoon. Okay, so if you can give me a wee nod to let me know if you can see that. Yep, good. Okay, so that's your heart, and blood essentially leaves the right hand side of the heart and goes to the lungs, and that's where it picks up oxygen. So essentially, all your blood from your veins drains into the right-hand side of your heart, into the right atrium. There's 4 chambers in the heart. There's the right atrium where the blood returns, and it's deoxygenated and then goes into the right ventricle, and then it's squeezed from the right ventricle up into the lungs, and in the lungs it picks up oxygen. Okay, and that's when it becomes bright red, because the oxygen is attached to the red blood cells. The oxygen rich blood then returns into the left-hand side of the heart. So it goes into the left atrium and then into the left ventricle. And it is the left ventricle that squeezes, this part of the heart here, that squeezes and pushes the blood right up into your aorta. And this is the biggest artery in your body. And this then comes out of your heart, folds down and comes down the rest. So this is your aorta coming down through the rest of your body, and essentially all the arteries come off the aorta and go to the rest of the body. So some will go up into your neck and into your head, others into your arms, and then you'll obviously need a blood supply to your organs like your kidneys and your gut, etc., etc. And then the aorta bifurcates in your pelvis into 2 big arteries that run down into your legs. And then, as I said, the blood returns via veins into the right-hand side of the heart. Okay, so now something else with this picture. The heart needs an oxygen and blood supply itself because it's a muscle. And this is done by these 3 main arteries. Now, you don't need, these are coronary arteries. You don't need to remember the names of these at all. But you've got the right coronary artery. You've got the circumflex, and then you've got the left anterior descending artery. And the reason why I'm mentioning these is just because that is where, if you get problems with your heart, you've got heart disease and you've got fatty plaque buildup, those are the arteries that the cardiologist will chat about. Okay, so they may mention the circumflex, the left anterior descending, or the right coronary artery. All right. And because the heart's a muscle, like anything else, it needs to be worked like any other muscle because it has an oxygen supply. Okay, so we're now going to go on to the symptoms of coronary heart disease. So this is where you guys are going to help me out. And we mentioned this a little bit last week. So can anybody tell me what kind of things you might feel if you had problems with your heart?
Palpitations.
Palpitations, yep. So you may feel kind of a fluttering in your chest or your heart racing. Patients often describe it.
Breathlessness.
breathlessness. Yep, shortness of breath. So that's something else we'll ask about, breathlessness. And that's essentially because your heart's not working as well as it was before. And that affects the oxygen supply to lots of your different organs in your lungs and things like that. So you get breathlessness. Yep.
Pain on exercise.
Yeah, so pain on exercise, and that's a good point. So we'll ask about what happens when you exert yourself. And the very simple question I often ask in clinic is, if I asked you to walk up a flight of stairs, how would you feel? Would you be short of breath? Would you have any pain? Okay.
High resps.
Say that
High
again.
respiration rate.
High respiration, yes. So that kind, yeah. So yep. So tachypneic as opposed to tachycardic. So tachycardic is a fast heart rate, but you could have a high breathing rate, which the patient may say they're short of breath. Yep, and they feel they're breathing heavier. You can feel faint or sick. All right, you can feel quite nauseous if you're having issues with your heart. You can also get the pain. Can anybody tell me about the pain, where the pain would be?
Left arm, chin, or jaw area.
So pain can be in the chest. So the most common place for pain would be chest pain, slightly to the left-hand side because your heart is slightly to the left. It's not right in the middle. And yeah, it can radiate down your left arm and into the left-hand side of your neck or jaw. And I find this absolutely fascinating as a medical student. I think this is one of the quite quirky things that I really love about science or medicine, or the human body. So the reason why your left arm and your left jaw get sore is because the nerves for your left arm and left jaw go into your spinal cord round about the same area as the nerves from your heart go in. So you don't actually have a sore left arm or left jaw. Your brain's just not good enough at determining where the pain's coming from. So there's absolutely nothing wrong with your jaw or your left arm, but it's the brain can't figure out where the pain's coming from. It's coming from your heart, but the brain's not good enough at discerning. So that's why you get left arm and left jaw pain. But you can feel faint, sick, or nauseous. So the chest pain, the technical term for the chest pain is angina. Okay. And we've already commented that the pain may come on with exercise, with exertion, going up a flight of stairs or walking or whatever. So the angina, we then can say, is either stable or unstable. So if it's stable, that is when it only comes on with exertion. All right. And I always think of stable angina is a warning shot. So you may be quite disappointed to find out you've got stable angina, I would suggest, when you start developing chest pain. But for me, I think it's quite good because you know there's an issue with your heart and you can go and get investigated and get treatment, as opposed to having the frank heart attack and dropping dead. Okay, so you've always got to think there's a silver lining. So stable angina is when the chest pain comes on when you exert yourself. So it might be you notice it when you're walking, particularly up a hill. You may be okay walking in the flat, but as soon as your heart is put under more strain when you walk up a hill, and you'll notice this if you're out walking and then, or you're out hill walking and you're flat to begin with, and then you start walking up a hill, you'll be breathing heavier and your heart is working harder. And stable angina is when the pain comes on when you're where all the symptoms, shortness of breath, pain, etc., come on when you're exerting yourself. Unstable angina is a lot more worrying because it comes on when you're at rest. So it may come on while you're watching TV, or it may come on in bed, or when you're doing nothing. Okay, and that's kind of more of an emergent sign. Okay, and if the pain, the angina comes on and lasts for 10 minutes and it's not relieved by any of the medications you've been given, you must present to A&E or your GP. Okay, because that's really quite serious. Now, you can also have asymptomatic heart attacks or chest pain or angina, and that may happen in older people, or it may happen in people with diabetes. And essentially, someone with diabetes will have problems with their nerves, so they may not feel the chest pain. Okay, and people will have had heart attacks that they may have had a week or two before or whatever, and they'll be in hospital for whatever reason. They may be unwell or whatever, and somebody will say, oh, you've had a heart attack before, and we can tell that by the ECG, the electrical traces and things like that, or you may get other studies done such as echoes. Okay, so The symptoms of coronary heart disease are chest pain. It can be called angina. It can be stable or unstable, depending whether it's related to exercise or not. You can present with shortness of breath. The pain may radiate down your left arm into your neck. You may feel faint, sick, nauseous, or you may be asymptomatic. So that's kind of angina. In terms of having a heart attack, you'll often speak to people and it is a sense of impending doom. It's supposed to be quite horrific, and it often feels like an elephant sitting on your chest. People report that it's really, really horrific and you feel absolutely dreadful. And it's a sense of impending doom. Okay, and the patient will obviously be very pale, sweaty, and just look pretty awful. Okay, so causes of coronary heart disease. We chatted a little bit about this last week. It's all got to do with the buildup of fatty substances in the coronary arteries. So I've just shown you a schematic of the heart with the 3 coronary arteries, the circumflex, the left anterior descending, and the right coronary artery. So I'm going to show you another schematic now. Basically the same thing, but slightly different. Okay, so essentially, this is your heart, and these are your left anterior descending, your circumflex, and your right coronary artery, as shown in the previous cartoon. Now, normal arteries, in inverted commas, there's nothing really normal about anybody, I would suggest, but a healthy artery, you could call that. You can see as whistle clean, the endothelial wall of your artery is clear and the blood cells will just flow along here without any issues, okay? And I often liken your arteries to hose pipes, okay? In B here, we've got a buildup of your fatty plaques, all right? And you can see blood flow through here is not going to be as smooth. It's going to be more difficult for the blood to flow through here. And then C basically shows what happens when the plaque ruptures, okay? And this can result in a blockage from a blood clot, and that can result in a heart attack if it's your heart, or a stroke if it's in your head, okay? So that's essentially the process. So you have a buildup of the fatty substances in the coronary arteries. Up to about 70% of a blockage, you may not have any symptoms. When you get to 70% blockage, that's when you will start to have problems with angina, whether it be stable or unstable. And it's essentially just, and I really love the term, the furring up with fatty plaques, okay? The process, the technical term for the process is atherosclerosis. And the fatty plaques are called atheroma, but I'm good to go with fatty plaques, okay? I call them fatty plaques all the time in clinic because it kind of gets the message across. The term atherosclerosis is essentially just the furring up or the blockage of your arteries with fatty plaques or atheroma. So the plaques occur at areas where the blood vessel has been damaged, okay? And this may be due to inflammation or turbulent blood flow, and we'll come back to that. The buildup of the fatty plaque decreases the blood flow, makes it more turbulent, and narrows the passage of blood through that. And as a result of that, it restricts the amount of blood and therefore the oxygen supply to the organ that it's supplying. So in this case, the heart. And when you get that plaque rupture and the thrombus or the blood clot forming, that is when you get your heart attack. And it's usually a dull pain in the center of your chest, as if someone's sitting in your chest, and a sense of impending doom. All right. And if it's in your head, it will result in a stroke. This process won't just be going on in these 3 arteries, okay? If this process is going on around the arteries in your heart, the chances are it's going on elsewhere in your head and in your legs. And the converse is true. If it's happening in your head, there will be some issues in your heart and your legs, okay? Some patients present with all 3. We'll have patients who have problems with their heart, their head, and their legs. They'll have all 3, and they're called arteriopaths. And those are the ones that we have to try very, very hard to reduce the risk factors, okay? when you have narrowed arteries, even before you have a heart attack or whatever, it's putting a strain on your heart and it's having to work harder to pump blood through your body. And that can result in heart failure. And you can also have heart failure after you've had a heart attack, because when you've had a heart attack, part of the muscle, depending how quickly the blockage gets unblocked, for want of a better word, so depending how quickly you present at hospital and the blockage is either you get treatment to thin the blood and to bust the clot, for want of a better word, or you get what they call percutaneous coronary intervention, where they essentially, PCI, basically pipe cleaner up round your arteries, okay, and they put a stent in, which I like to think of as the inside of a big barrow. Anybody that actually makes stents would burst into tears, and any cardiologist would burst into tears, but I like to keep things really, really simple. Okay, the whole idea is they put a wire, a guide wire, up into one of your main arteries, either in your groin or in your arm, goes round into your heart arteries, and they slide a stent over that, and the stent goes into the artery and squeezes the fat, okay, and then the blood can flow through again. That's essentially what stenting is. All right. In terms of the blood clot forming, the fatty plaques become quite hard on the outside, okay? It creates an uneven arterial surface. The fatty plaques often on the outside become calcified. And as a result of that, they can become quite easy to rupture, okay? And as a result of that, if they rupture because of, for example, high blood pressure, because the blood flow is a lot more turbulent over this fibrous hard cap that's got calcium in it, and when that ruptures, that sets off your natural clotting cascade, and that's when you get your blood clot, and that's what leads to your heart attack. Okay. Okay, so has anybody got any questions about that? That's a lot of information. All I really want you to take from it is your heart's a muscle. It needs a good blood and oxygen supply because it is the big muscle that is pumping blood all around your body. It's got 3 big arteries, okay, because it needs oxygen and blood. As we get older, these arteries tend to fur up, okay? This furring up is allegedly supposed to start when we're in our 20s. Okay, so it takes a lot of years for these to fur up, okay? That process may be accelerated by certain risk factors, which we're going to come on to shortly. And then if you get to 70% or more of a blockage, that's when you're likely to get symptoms, okay? And the symptoms are essentially angina. And if it's stable, it comes on with exertion. With exertion, and if it's unstable, it may come on at rest. But if you get stable angina, that's when you go and get reviewed by your GP and referred to cardiology, et cetera, and we'll come on to that in a little minute, okay? And if the fibrous cap of the plaque ruptures, that's when you can get a blood clot, and that's when you can have your heart attack. Okay. Anybody get any questions about that? Please do ask. No, everybody wowed by the science. Fascinating. It is fascinating. It is fascinating. All right. Cardiometabolic disease at the moment is really taking off because the things that contribute to your fatty plaque buildup, et cetera, really, really interesting. Right, which brings me nicely on to the causes of coronary heart disease. So we chatted a little bit about this last week, but we're going to go over it again. So there are risk factors, modifiable and non-modifiable. So we're going to quickly go over the non-modifiable again, really, really quickly. There's 4 of these.
Your age.
Yep, your age. So the older you are, the more likely you are to have heart disease. That kind of makes sense.
Genetics.
Yep, genetics are important. You may have a strong family history of heart disease. And by that, I mean a first-degree relative, your mum and dad's siblings under the age of 60, or a second-degree relative, your grandparents, cousins, etc., under the age of 50. Oh, sorry, there's a chat there. Let me see. Ooh, you mentioned calcification. Is this drinking too much kefir? Can you overdo calcium? Sorry, I've silly. No, say questions. No. Right, okay, so calcification is important. Calcium is one of those things you've got to be careful if you're supplementing it. I don't think you would overdo it with your diet. If you were drinking loads of kefir, which has, or taking a lot of yogurt, which has calcium in it, I think you would have to take so much of that to have an issue with your calcium that you'd be doing nothing but drink kefir all day or eat yogurt all day. I think the problem is you have to be careful with calcium supplementation. And this came out quite a few years ago. Lots of people with osteoporosis, and we'll do a session on osteoporosis. So lots of ladies with osteoporosis were put on calcium and vitamin D supplements quite readily many, many years ago. And then they showed that the calcium probably wasn't needed as much as the vitamin D per se. Or you could supplement with just vitamin D, not calcium. And we usually do that. We only supplement with vitamin D9, not calcium, not unless the patient's calcium is low for whatever reason. But if you've got a good diet, you should get enough calcium in your diet. You don't want to take calcium supplements if your calcium is within the normal range, because that excess calcium from supplementation could increase your calcification of your fatty plaques. Okay, but you shouldn't overdo it with diet. All right. And there's never a silly question. Okay. Okay. So age, genetics, yeah, family history. So you might have a genetic predisposition to having a high cholesterol called familial hypercholesterolemia, where you've got a high level of cholesterol, or you may just have a family history of heart disease, as mentioned. So that's age, genetics. Anything else?
Ethnicity.
Ethnicity, yep. So ethnicity affects where you lay down fat, which can affect your cardiovascular risk. And then the other one is your sex. Okay, so men tend to have increased risk of cardiovascular disease about 10 years earlier than females. But once we go through the menopause at the age around about 50, we surpass men. Okay, and this is something we haven't really known a lot about until the last 5 years or so. Okay, it's coming more into the limelight that females have an increased risk of cardiovascular disease once they go through the menopause. So those are the non-modifiable risk factors. We can't do anything about those. You know, we're going to go through the menopause. We're getting older, and your ethnicity and your sex, or your ethnicity and your sex. It is what it is. So modifiable risk factors. I'm not saying they're more important, but they're, at least we can modify them. That's the whole point. So let's run through the modifiable risk factors again.
Diet.
Yep, diet's important. Okay, so nutrition is important.
Smoking.
Yep, smoking is really, really important when it comes to heart disease. And the reason why smoking is important is because smoking accelerates the laying down of the fatty plaques. And I'll cover this when I'm chatting about cholesterol. So the smoking results in the oxidation of LDL, the bad cholesterol, and oxidized LDL is taken up by the macrophages, or the white cells that take up the oxidized LDL, become foam cells, and it is the foam cells that are laid down on the inside of the artery wall, and those form the fatty plaques. So lots of people have got the association between smoking and lung disease, but I don't think we've got the kind of public health message across as well, that it is increased your heart disease. And peripheral vascular disease, apparently you're on a hiding to nothing if you've got peripheral vascular disease and you continue smoking. Really, really bad for peripheral vascular disease. And it's one of the first things the vascular surgeons will be hounding you about. Okay. Problem with smoking is it's addictive. Okay. We all know it's addictive. So it's really, really quite difficult for some people to stop. Okay. Okay. Smoking, nutrition.
Weight gain around your abdomen.
Yep. So your body habitus, your body mass index, and we'll take that as it is. But yeah, your waist circumference, very important. And that all plays into your waist circumference is really important, because if you've got weight around your abdomen, a little bit will be under your skin, subcutaneous, but the rest of the fat will be around your liver. And your fatty liver, we know, precedes insulin resistance by about 10 years, and insulin resistance leads on to type 2 diabetes. And your insulin resistance and having metabolic inflammation due to the weight around your abdomen all results in different signaling molecules and results in damage to your arteries. Okay, so that is all tied in, and that's why if you've got diabetes, insulin resistance, or a fatty liver or weight around your abdomen, you've got an increased risk of cardiovascular disease. Good. Anything else? High blood pressure is really important. Yeah, high blood pressure is really important. And the reason for that is I've shown you in a schematic there that when you have the fatty plaques laid down, the blood flow is more turbulent. You know, it's not as easy as going through the whistle clean artery. The blood has to go over these bumps and grooves, and high blood pressure makes that flow even more turbulent. And the more turbulent the blood flow is, the more easy the fibrous calcified plaque can rupture, and you can get the blockage. So that's why blood pressure is really important. And blood pressure, high blood pressure is really good association with strokes in particular, okay, for that reason. Diabetes. Diabetes is one of your modifiable risk factors for cardiovascular disease. And again, that's all got to do with having high blood sugar levels. And again, that can damage your large and your small arteries in the body. And if you get type 2 diabetes, the chances are you've got more weight around your abdomen, fatty liver, etc., etc. So those all tie in together. And the other thing is cholesterol. Okay, having a high cholesterol is obviously one of the modifiable risk factors. And whether that may be genetic, it may be slightly diet related, or it may be to do with your body habitus. Okay, and alcohol is also important when it comes to heart disease. If you're a chronic heavy drinker, you can get what we call cardiomyopathy, which is a big floppy heart. All right, so alcohol pretty much affects every organ in the body, but you can get cardiomyopathy. Alcohol also affects the processing of your lipids by your liver, and we'll do a session on this. It results in high triglycerides, which can result in a fatty liver, and your fatty liver then can result in insulin resistance, increases your cardiovascular risk, and also the triglycerides are tied in with a higher cardiovascular risk. So they're all tied in together, okay? And in terms of nutrition, a diet with quite a bit of refined carbohydrate will result in fatty liver and high triglycerides. Okay, so in terms of diagnosis, if anybody's chatting about cardiovascular disease or has an issue with any of the symptoms, if you're reviewed by your GP, the family history is very important. As I said, it should be heart disease in a first degree relative under the age of 60, second degree relative under the age of 50. Everybody will pretty much have a history of cardiovascular disease in their family if their parents have lived long enough. Okay, so anything over the age of 60 is not taken as a significant family history. But I had a patient in yesterday whose 3 brothers all either passed away or had heart disease in their 40s. That's a really strong family history. Okay. It can be a wee bit messy because I live in the west of Scotland, so my patients are in the west of Scotland, and I have lots of people who have possibly first degree relatives who've had heart issues, ischemic heart disease in their 50s, but they may have been overweight, they may have drank a lot, they may have smoked. Okay, so it's not as straightforward as that, but in general, we go for under 60 and under 50. Okay. Lifestyle. GP should ask you about your lifestyle. All right, as well. Just find out about your exercise, and what type of nutrition. Nutrition's a bit funny when it comes to cholesterol. Some people, depending on their nutrition, your cholesterol can be affected quite a bit. Others, they can change their diet or alter things and their cholesterol doesn't budge. And that's because 80% of your cholesterol is controlled by what's going on in your liver, only 20% by your diet. And it seems to vary quite a bit between patients. And it's not that easy to, well, sometimes it is. If the diet's particularly poor, you'll have a fair idea that if they alter their diet and then get retested, it might change. But I had a gentleman once who decided to go vegan. I was very excited by this because he go vegan for 9 months before I saw him again. And I thought, oh, it's only N equals 1, to be fair. Vegan LDL didn't change a jot. And he only ate plant food for 9 months, which was quite interesting. So you've seen your GP, you've given a history, simple blood test that you get done if we're concerned about cardiovascular or heart disease. Get your kidney function done. Per kidney function increases your cardiovascular risk. You also need your kidney function done because you may be put on medications, and you need to monitor your kidney function, so you'll need a baseline set done. You get a lipid profile. That's really important. We want to look at your cholesterol and your triglycerides. And don't worry, we'll come back to those in individual sessions. Also get your liver function test done. And the reason why we want liver function done is we want to see if they're deranged a bit, it might point towards a fatty liver. Okay, and again, that's all part of your cardiometabolic risk. I would also possibly do an HbA1c, and again, we'll do this again when we're chatting about insulin resistance and diabetes. I often do this in patients. I don't think they're frank diabetic, but I want to see if they're insulin resistant, because this is the stage where we can reverse things. Okay. You should also get your blood pressure done. Now, a one-off blood pressure doesn't really tell you very much, and it definitely doesn't tell you very much when you come to my clinic, because nobody wants to come to my clinic. I try not to take that personally, but nobody really wants to come to hospital to go to a clinic to see a doctor. You'd be a bit odd if you did want to. Parking's always a nightmare as well, or if they've got the bus, the bus has usually been late and they've come careering up the hill. So a one-off blood pressure doesn't tell us very much. If someone does have a high blood pressure, we can get it redone at the end of clinic. That doesn't make a lot of difference though. But if they've got a blood pressure monitor at home, I often ask them to go home, relax for an hour, have a cup of tea, and then redo their blood pressure and see what it's like. One of the best ways to know what your blood pressure is like is to have your own monitor at home, and it's to do it over 7 days. So I often chat to patients in 7 days, starting on Monday, twice between 6 a.m. and 9 a.m. in the morning, twice between 6 p.m. and 9 p.m. in the evening. Do it over 7 days. Disregard the first day's results because everybody gets a little bit excited. You then have 6 days, 4 results, which is 24 results. And you should, if you write those all down, you can bring those to your GP and they can have a look at your blood pressure. And if you have high blood pressure, that's something you should probably do every so often. I would suggest every 3 to 6 months, just to keep an eye on it, even if you're on medication. 2 reasons. One, it may not be being controlled by your medication, or indeed, if you're losing weight or exercising more, your blood pressure may be going down on your medication and it may be able to get reduced. But blood pressure is important.
Sorry, can I ask, you said 2 times in the morning between 6 and 9 and
Yep.
twice in the evening. What was the time?
Between 6 and 9. Those are just arbitrary. It's just kind of, in the morning and in the evening, but 6 to 9 kind of covers before work if you're going to work, and 6 to 9 in the evening should be out with work as well. Okay.
Perfect, thank you.
I think that's been shown to be more useful than having like a tape on for, or, a blood pressure for 24 hours. There's nothing like having a blood pressure monitor on for 24 hours to put your blood pressure up, I would suggest, because I can't think of anything more annoying. And that's just, there's been several papers that shows, just doing it with your own monitor over a week is quite good. Some other people will just do it once a week, a bit like you do your weight once a week. They just do their blood pressure once a week. It would probably depend what day I did it on for me though, to be fair. So further tests, if you have symptoms of chest pain and it sounds like, stable angina, the kind of gold standard is CTCA, which is CT coronary angiography. All right. Now, interestingly, I had a patient yesterday ask me about getting one of these done, but she's asymptomatic. So she will not get one done in my health board in the NHS if she has not been reviewed by cardiology and she's asymptomatic. You could probably get it done privately if you're asymptomatic, if you wanted to have a look to see, but you will definitely not get it done on the NHS. And I believe it's quite funny, actually. It's kind of gold standard. So anybody we think who has chest pain or it sounds cardiac in nature should probably get a CTCA. But the waiting list is huge, even for people who are symptomatic. So one of the things they will get done in my health board is they will be referred to the rapid access chest pain clinic. And this happens by GPs. I can't do this directly. I have to ask the GP to do it. And you will get an exercise tolerance test. And that is where they put you in a treadmill. They put the treadmill on a bit of a hill and they ask you to walk. It's a protocol for about 5, 10, 15 minutes. And they will, got all your stickies on you for your ECG. So they will look at the electrical activity of your heart whilst you are exercising to see if there are any changes. Okay. Other tests you can get done is you can get the, if you've got what they perceive as blockages, you might get your percutaneous intervention, and that's where they can do that if you're having a heart attack to put the stent in, but they can also do that electively where your exercise tolerance test, I think you would probably go from an exercise tolerance test that was positive to CTCA because they'd want to have a look to see what's going on and where it's going on so that the guys know where they're going to stent. You may not get stented, okay? If, and I was chatting to medical students about this last week, if you've got a blockage or a bit of a blockage in a specific area of one of the 3 arteries or 2 of the arteries, they may put a couple of stents in. If you have diffuse disease, and that means you've kind of got disease all along the artery and not in a specific place, they will not stent because they can't put lots of stents in the same artery. And that's where you'll get something called a coronary artery bypass graft, a CABG, which is commonly known as a cabbage. All right. But that's where you get your chest cut open, and they do kind of open heart surgery because they have to take one of your veins from your leg and they literally bypass the diseased artery. Now, that was a lot more common many, many years ago, about 40 years ago. They did those routinely. I think they don't do them as much now because they hopefully find people earlier with kind of more focal disease, and then they put the stents in. All right. And the stents, I know I kind of joked about it being the inside of a big barrow, but the stents are really fandangled these days. There's lots of different types of stents, and there's stents that elute drugs to keep the blood thin, etc., etc. And that's another area in its own. Okay. I've written here that treatment of coronary artery disease cannot be cured, but we can manage the symptoms. And yeah, I think most of us will have been building up plaques since we've been in our early 20s. It's a long process. Some of the drugs, though, now that we can give have been shown. They're now looking at studies. It used to just be preventing further heart attacks and strokes, etc., with the medications we use. But they're now, lots of these trials actually look at the buildup of the fatty plaques, and they've shown that some of the medications can actually reduce the atheroma. I think there's some evidence now also that healthy diet, etc., and lifestyle changes can help reduce the atheroma. Got asked yesterday though, can I get all my plaques, atheroma removed? No, we don't have something to suck it all out, for want of a better word. All right. So treatment is often, if you've had a heart attack or a stroke, you'll definitely be put on medication. Okay. You'll be put on a statin as first line to reduce your cholesterol. And it doesn't matter what your cholesterol's like. Your cholesterol may not be that high. They'll still put you on a statin, okay? You don't have to take it, but they will offer you a statin, should I say, and antihypertensive. So you'll get blood pressure medication as well, and you'll get blood thinners as well. Lifestyle changes are really important though. I get lots of referrals to clinic from cardiology where we've got the LDL down quite low. The cardiologist wants it down even lower, but the person's got a body mass index of 40 and really poorly controlled diabetes. And I think we're kind of missing a lot of the point here. All right. There are 5 or 6, if we've talked about modifiable risk factors. There is no point in hammering one of them and ignoring the other 5, I think. Okay, that's just my personal opinion. Okay. We've got to work on all the lifestyle changes. So we want to reduce weight if we're overweight, especially weight around the abdomen. We want to exercise regularly, regular exercise, out with even resistance training, but cardiovascular exercise, so more walking or doing swimming or whatever works your heart. Your heart is a muscle. Exercise, cardiovascular exercise also helps keep your arteries healthy. Okay, as we get older, we lose elasticity from our arteries, which is why our blood pressure goes up as we get older. All right. Regular exercise will help with that. We want to stop smoking. Medications have their place, particularly in secondary prevention, not necessarily in primary prevention. I would always try and tackle that with lifestyle. Primary prevention is basically you haven't had an event. Once you've had an event, I think medications definitely have their place. Okay. And then you've got angioplasty plus or minus stent. So that's, again, putting your pipe cleaner up and putting your stent in if you require it, or the surgery if you've got diffuse disease. All right. But lifestyle is really, really important in terms of cardiovascular disease. Walking, for example, if you just take walking on its own, walking will help maintain weight because you're moving, you're using calories. It's non-exercise activity thermogenesis. All right. It helps with insulin resistance. Okay. Insulin resistance, type 2 diabetes all increase your risk of heart disease. Helps with your fatty liver, which helps with your cholesterol and your triglycerides. Mental health. Okay, really, really important. Really, walking is one of the best things for stress, being out in green spaces. All right. And that's just one thing you can do in terms of lifestyle. So most of us, as I've said at the beginning, will have already got fatty plaques in our arteries. Okay, I will have fatty plaques in my arteries. I can make the gross assumption that they're not big enough to cause me angina, because when I go out for a run or a walk or go up a hill, I don't have any issues. All right. I'm hoping by the lifestyle changes that I've made over the last 3 or 4 years that I have decreased the progression, slowed down the progression of those fatty plaques. Whether I've lessened the size of the fatty plaques, I don't know. Never had any investigations done. I don't intend to pay for them. But I will hopefully that the lifestyle changes will stand me in good stead. So eating a healthy and balanced diet. All right. I know one of the measurements I do know is my cholesterol. I've had that measured, so I know my cholesterol's okay. I watch my blood pressure and also my weight around my abdomen. All right. So there's lots of things you can do out with medications or surgeries and things like that if you haven't already been diagnosed with heart disease. Okay, anybody get any questions about any of that? Your heart is a serious bit of kit. It's a fantastic bit of kit. If you think about it, it pumps between 60 and 100 beats per minute. Say it pumps 80 beats per minute and you're 80 years of age. Never done the maths, but that's a lot of pumps, beats, all right? You know, I doubt there's a man-made pump that would ever do that amount of work without failing, okay? I mean, it really is a serious bit of kit, but you have to look after it. Okay. Okay. Anybody get any questions?
I've got one, which is when we talk about our waist measurement, isn't there sort of some ratio to your height and weight? I remember seeing Michael Mosley doing
there's a waist to hip ratio you can use.
Oh, okay, maybe
it's a waist. Yeah, it's a waist. So your body mass index is your height and weight ratio. Okay. Yeah. Your waist circumference can, and I'll do this in a session. I do a session when we're talking about measuring weight, whether we use a, you know, or looking at fat and whatever, or, you know, whether you use your bioimpedance scales, whether you use your calipers, whether you do BMI. The two I use are BMI and waist circumference, but you can do a waist to hip ratio. I don't do a waist to hip ratio because I don't think it tells me any more than just the waist circumference. So why, you know, so in clinic, I'm not going to measure two things and then work it out because it doesn't tell me anymore. Okay, but I think it's the waist to hip ratio you're talking about. Does that help?
Sorry, while you were talking, because there's noise in the background, I put myself on mute. Yeah, no, that really helped.
So yeah, I think it's, and we'll cover that in a couple of weeks' time. It's a waist to hip ratio, I think.
Okay. And you might be covering this in a minute, but what's a healthy waist measurement?
Yeah, so we'll do that when I do body mass index and waist. So for females, it's less than 80 centimeters. Yeah. Sorry, I can never remember the inches. And for males, it's less than 94 centimeters. Okay. Now, here's the thing. Do not panic, because you're all now going to go off and get your tape out or go and look at last week's, whatever your waist was on Thursday, because you're all tracking it. And you're all going to say, oh my God, my waist's more than 80 centimeters. Invariably, it will be more than 80 centimeters. Okay. But here's the thing. It will have come down since when you started TSD, all right? And any movement down the ways is good. The other thing is we know we can't spot reduce. And when I started TSD, my waist measurement was more than 80 centimeters. And I lost weight from everywhere but my waist, okay? I found it difficult to shave under my armpits for the first time. I mean, who the hell cares whether you've got weight under your armpits or not? In my groin area as well, where my muscles join my my inner pelvis, I lost weight there. And again, who gives a rat's ass whether you've got weight there or not? But the tummy was doing the same thing. I also, since started TSD 4 years ago in January. And when I put weight on, a little bit of weight on, it immediately goes to my sides. Okay, I've got these little things that I call my chipmunk storage things, okay? And that's just where it goes. And that's genetically predetermined where my weight goes when I put it back on. So do not panic. The idea is that your weight will come off, it will come off from lots of different areas, but if you keep working at it and working away, and any weight loss from your waist or and your liver, even without weight loss, with just changing your diet and increasing your activity, will benefit. Okay, so do not get hung up on the 80 centimeters, but that's your kind of ballpark figure for, if you go onto the British Hypertension Society website, they'll tell you all about your waist circumference and what it should be and stuff. All right. But I don't want everybody panicking because they don't have an 80 centimeter waist circumference. As Tristan always says to me, Tristan was my coach when I went through TSD, and you know, it takes 10, 15, 20 years to put all this weight on, and we all want to lose it in 3 months. It's just human nature, isn't it? Okay. Yep, your belly fat probably will be the last to go, but it's fine. The stuff you're doing now is helping you in terms of your health, irrespective of what's happening to your belly fat. All right, do not panic. Okay, any other questions? Yeah, no, the armpit thing was a bit odd. To be fair, I didn't think I had weight in my armpits to lose, but anyway, there you go. And also I'm not very large chested, but mine up round here, you can see my clavicles and my ribs at the top as well. And again, who cares about that? But anyway, it is what it is. Presumably, I just think the whole thing. And yeah, your measurements are useful, aren't they? Okay. Okay, any other questions? Because that's pretty much me. So the whole idea is coronary heart disease. It's the buildup of fatty plaques in your coronary arteries. There are 3 main coronary arteries that wrap around your heart. Okay. If you have symptoms of heart disease, you typically start off with stable angina, where you'll get chest pain, shortness of breath when you're exercising. All right. And at that stage, it's really, really important that you get to your GP to get referred to cardiology for further investigations. Okay. If you have a blockage, it's when you have the heart attack, that's the impending doom. All sounds pretty horrific, but we can do lots of things because we know there are 5 or 6 modifiable risk factors that we can chip away at every day and make little changes and just keep going. And it is a really slow process, as in when I started TSD, oh my God, you got tons of stuff thrown at you and you didn't know where you were at and what was upside down. 4 years down the line, there are tiny little things. So last week, I think I just started, I was trying to do yoga once a week. I like yoga. I never have time for yoga. So I've now resigned myself to a exercise snack. So I do 5 to 10 minutes of yoga every day. And that's working really well for me because for whatever reason, I couldn't find half an hour or an hour to do yoga once a week because of all the other stuff I do. But I got 6 minutes of yoga fitted in before I started this morning. Okay, I was quite pleased with that. So about 5 minutes before I came on with you guys, I was down dogging and planking and doing all sorts of stuff. All right. But it's just really, really nice to do for 5 or 6 minutes, and it's good for your mental health, etc., etc. So just keep plugging away, keep stacking your habits, and everything you're doing will be improving your health, even though you don't see some of the physical signs. All right. Okay. Well, look, lovely to speak to everybody this morning. If there are no more questions, that's me. I think we're going to chat about blood pressure and stroke next week. Okay. So that'll be a little bit more about blood pressure. Okay. Lovely to speak to everybody this morning. Have a great week, and I shall catch up with you next Wednesday.
Thank you.
Thank you.
Bye.
Thanks. Bye.
Thank you.
Thank you.
Bye.
Thank you. Bye.